Both have hypercalcemia.
Where do we start?
First, decide who needs treatment now. As calcium rises, symptoms become more severe, from mild fatigue to confusion and cardiac effects.
So we shouldn't wait cause?
Exactly. Severe or symptomatic hypercalcemia is a medical emergency. Stabilize the patient first.
So, does every hypemia mean true hypercalcemia?
Not always. Correct for measure ionized calcium. Albumin carries calcium. When albumin falls, total calcium falls, but ionized calcium may stay normal. Low albumin can hide true hypercalcemia. Correct the calcium or measure ionized calcium to confirm the diagnosis. Luna, we've confirmed true hypercalcemia.
Measure the parathyroid hormone PTH.
Is the PTH high or low? Luna, if the PTH is elevated, what does that tell us?
The parathyroid gland is causing the hypercalcemia.
Hypercalcemia. Now let's determine why the PTH is elevated. Luna, both primary hyperparathyroidism and FHH have elevated PTH. How do we tell them apart?
Measure the urine calcium.
Exactly.
Primary hyperparathyroidism overwhelms the kidneys. In FHH, the kidneys keep reabsorbing calcium.
There's one more important cause of PTH-mediated hypercalcemia: tertiary hyperparathyroidism, a complication of long-standing chronic kidney disease. Years of secondary hyperparathyroidism cause the glands to become autonomous. PTH stays high, even after calcium rises. When PTH is elevated, think of these three diagnoses. The clinical history and urine calcium usually identify the correct one. Luna, if the PTH is low, what does that tell us?
The parathyroid gland isn't causing the hypercalcemia.
Exactly. Now we look for causes outside the parathyroid gland. PTH is suppressed, but the tumor secretes PTH-related peptide. It mimics PTH and rapidly raises blood calcium.
Another important PTH-independent cause is excess vitamin D, which increases intestinal calcium absorption.
Luna, what does an elevated 25-hydroxyvitamin D suggest?
Vitamin D intoxication.
Excess vitamin D increases intestinal calcium absorption. Not all vitamin D-mediated hypercalcemia is the same. Sometimes the problem is excess 25-OH vitamin D. Other times, excess active 125 vitamin D. What does an elevated 125-dihydroxyvitamin D suggest?
Granulomatous diseases?
Granulomatous diseases or lymphoma. Activated macrophages produce How does osteolytic bone disease cause hypercalcemia?
Bone destruction releases calcium directly into the bloodstream.
These are the two major malignancy-related causes of hypercalcemia: PTHrP secretion and osteolytic bone destruction. What's the difference between these two mechanisms?
Mimics PTH. Osteolytic raises calcium by destroying bone.
Different mechanisms, same result: hypercalcemia. What happens when someone takes too much calcium carbonate?
It raises both calcium and bicarbonate.
That's how Milk-Alkali Syndrome begins. Why does the hypercalcemia keep getting worse?
Dehydration. The kidneys can't excrete calcium.
It becomes a vicious cycle.
Vitamin D is normal. Then why is this patient hypercalcemic?
Because the problem isn't excess vitamin D, it's an overwhelming calcium load. We've covered Milk-Alkali Syndrome. Next, let's review the medications that can cause hypercalcemia. How do thiazides and lithium raise calcium?
Thiazides reduce urinary calcium loss. Lithium increases PTH secretion.
Different mechanisms, same result. Luna, before ordering more tests, what should you always review?
The patient's medication list.
Sometimes the diagnosis is already in the medication history. We've covered medication-induced hypercalcemia. Finally, let's look at the remaining causes: hyperthyroidism, immobilization, and adrenal insufficiency. Excess thyroid hormone accelerates bone turnover. Bone resorption exceeds bone formation, releasing calcium into the bloodstream. Without weight-bearing, Bone resorption exceeds bone formation. Calcium leaves the skeleton and enters the bloodstream. Adrenal insufficiency causes volume depletion, reducing kidney filtration and calcium excretion. The result is mild hypercalcemia.
First, treat patients with severe or symptomatic hypercalcemia. Next, confirm it's true hypercalcemia. Then measure the PTHemia.
Then measure the PTH-mediated or
If PTH is high, think of the parath. If PTH is low, look diagnosis becomes much clearer.
Excellent. Excellent. That's exactly how physicians approach hypercalcemia.